Are you ready for headache?
Oh my God, it gives me a headache.
I have a headache talking about
yes,
headache.
Yes, that's exactly right.
It's a primary, secondary.
Oh yeah.
Okay, so the differential for headaches is extensive, and I'm not going to go through all of this.
Because we'll talk about these.
We're going to talk about all of them in a second. But essentially, there's sort of primary and there's secondary, and the secondary is really what we need to worry about and try to suss out.
Right.
So this is a good little sort of flow chart if you're a flow chart person to kind of go through. The key thing here is to ask for the red flags for headache, which we all know, right? First, worst, sudden headache, recent onset of a new headache without having history of it in the past, abnormal neuro findings, those types of things, vision changes. Right. Those are sort of your red flags. You know this. It's going to be fine.
And the list that's there is the stuff that really falls into that.
Right. So, we covered a lot of this already, but we're going to nail it in there for you.
Yeah.
Okay. So approach to a non-traumatic headache is really sort of focus on the high-risk features. And then if you find something that's concerning, you got to go look. You got to go for some neuroimaging, get a CT scan.
Or whatever tests are appropriate. Sometimes it's not a scan. Sometimes it's other kinds
of tests.
Sometimes
it's some blood
like a SED rate.
Yeah, totally. And without those high-risk features, neuroimaging is really not helpful and really unnecessary use of resources and radiation, right? Frowned upon. Don't do it.
Yeah.
But without these high-risk features, overwhelmingly, these are sort of primary headaches, like the migraines, the clusters and things like that, or sort of a toxic metabolic issue, less worrisome, right? The key is to pay close attention to a neurologic exam and the history. It's super important. So anytime you have someone with a headache, you're going to do a really careful history and you're going to do a really good neuro exam and sort of pick up on sort of high-risk features, find those red flags, and then go figure out what you need to do next.
Exactly. And the high-risk features are
acute onset. So really sudden, worse headache, thunderclap, that type of thing, I got to worry.
Exactly.
Right? Not having a history of headaches in the past, like there's no headache history, no migraine history, no family history. You got to worry about a little bit, especially if it's an older patient, like age over 50, I worry about, right? Anybody who's altered and seizing that had a history of headache before,
that's like
a huge, huge problem, right? We talked about vision changes being a really clue to something else neurologic going on as well. Exertional onset. I mean, if someone's exerting themselves and then has a really bad headache, like immediately I'm like, ugh, subarachnoid. This is the bad news.
Which is appropriate.
Yeah, right. And then anybody who's immune suppressed, like immediately their differential goes through the roof, and a lot of sort of autoimmune or infectious issues when they're autoimmune. It's like there's no immune system left is going to be a big problem.
Which we know that, right? We think about the HIV patients all the time.
Yeah, and there's different infections they get, right? And then if you're pregnant and postpartum, there's a lot of things that happen there, right? And then meningeal features, that's obvious to us. And, especially if there's multiple people affected and they all have that same headache, that's interesting. Maybe some carbon monoxide things happening, right? And then if you're on something that makes you bleed more, an antiplatelet, anticoagulant, definitely worry more about that. Anybody who has abnormal vital signs, obviously that's going to be a red flag. And then if you're looking for that temporal artery and it's painful, if they have pain with chewing, you might be worried about that as well. And then, if you're good at your panoptic, you're looking at the back of the eye and you've seen some retinal findings. We talked about that before, about sort of all the retinal badness that can happen, optic disc findings with papilledema.
And these lists sound talking about this sounds really silly, but we do often forget one or more of these things. And it's worth having even like a dot phrase available in this so that you actually have it in your dictation. And it reminds you, if you click your dot phrase and you read your dot phrase, reminds you to go
think about it again.
Think about it again, because you will help you pick up on the things that every once in a while you don't remember. Like, are you the only person in your family with this headache?
Right.
No, my kid has also had it too, and my other kid was throwing up this morning. It's like, oh wow, that's very different.
Right. Exactly. Okay, so imaging choices, right? So there's lots of different things that we can get. There's different types of CTs, non-con, angio, venous, and sort of to give you a framework, a little bit of sort of what you get, what depends a little bit on what you're worried about, right? So if you're concerned for a stroke or a mass or a hemorrhage or trauma, if they have hypertensive encephalopathy, you want to start with a non-con first and figure out.
Which is that PRES, right? Posterior reversible encephalopathy syndrome is that PRES on the slide here.
Yeah, and you want to go with the non-con CT first. Right? If you're worried about the vasculature, especially for cervical dissections, things like that, you want to get the CTA. If you're lucky, you can go for an MRA with an MRI as well, right? If you're concerned for venous thrombosis, you want to get the venogram, right? CT, venogram, or MR.
And that's important, right? It's really the only time you order that is when you're worried about that.
Right.
But you have to order that.
Exactly. And you have to be thinking about it too, which is the key. And then if you're concerned for an abscess, you want to get that CT with contrast, right? Or the MRI with contrast.
to image that.
Exactly.
So if we want to go into the primary causes of headache here, let's talk about migraine. Migraine. These are so common. Tends to be women, not all, but tends to be women aged 10 to 30, and it's recurrent. And they often have a positive, yes, everyone in my family has this, my aunt has this, my sister has this. And again, it's not only females. Men can definitely get this too, so don't get too niched in that box. This is a unilateral severe throbbing headache. It can last anything from just a couple hours to a couple of days. So, and people know, if they feel sick to their stomach, they may actually vomiting, they may have photophobia. People who have bad migraines will often they have their own concoction, their own system. They go into a dark room, they cover their head with a blanket, they use whatever works for them for their headache, and they know they're in for the duration, because people will often have these things last for a couple of days. There are migraines and the whole classification of headaches has really changed a lot in the last probably 5 years or so, the sort of spectrum of headaches. There's classic headache, the classic migraine, there's the migraine without, which is with an aura, there's the migraine without an aura. They even consider tension headache kind of in the vascular spectrum of headache, so it's really changed. And honestly, clinically, it doesn't really matter. For a neurologist, it matters on how they follow people and what they may do. For us, is just to put it into the right box of migraine. So the classic, of course, is the person who says, I had the scotoma, I was just hanging out, and then I couldn't see the center of my vision. I don't get migraines, but I get hemianopsic migraine equivalents where I lose half my field of vision.
Really?
Oh yeah, it's the weirdest thing. I thought I was having a stroke the first time. It was just awful. But that can be equivalent too. So the classic migraine has scotoma and they may have focal neurologic deficits with this. So that's like mine was a classic, but I never got a headache.
But it's a diagnosis of exclusion.
It is, definitely.
So if you see somebody who has neurosymptoms plus headache, you're worrying about the other things.
Yeah, you go do that first.
You might end up landing on
unless
this later.
someone says, like I would say to you, no, I always get this. This is exactly what happens to me. I get this thing, it lasts a couple of hours, I get these little wiggly things that's done, and I'm done. I never get a headache. Most people do get a headache, by the way, just to know that they get that with this. But again, you are going to, that first one, you're going to go or another, I get them all the time, but this one's
a little
different. That will clue you in. And the aura is the area of the brain involved. So for me, it's got to be my posterior fossa somewhere because I got a hemianopsia in here. That's what's going on probably for me. For other people, it may be they can get hemiplegia. They can get all kinds of, and the thing about this is stroke symptoms usually are maximum at onset and don't change. These may progress and regress, and that tells you that it isn't a stroke. You're still going to go ahead and work it up. But as far as reassuring yourself, it clues you in that this may be actually a migraine. Migraines without aura, some people will get migraines with no aura at all. And the only reason we put this slide in there is this is what it takes to get actually diagnosed with that as a diagnosis that you carry in your chart forever. And this is what our neurology friends will use to kind of determine, do you really have enough criteria to be a migraine without aura, that you end up with these headaches that are severe and throbbing. But you don't get this visual whatever or this neurologic whatever ahead of time. This is what you get. So this is just for your information. The reality is we would pick up this is a migraine as well. And the key to migraines is, if at all possible, prevent them. You just would prefer it not to get in and then anchored in, because it really does last a while when people get the headache part in particular. And there's a whole list of choices here to treat migraines. I think it's fascinating that there are MABs that work. I just think that's incredible. MABs are the whole antibody immune.
There's MABs for everything now.
There are. It is whacked out. It's really cool. I was listening to NPR this morning talking about
Pharma is not
MABs
around
for cancers that are like, it's amazing. It's amazing. If they come to us though, and it's in place, it's happening. The key really is not to feed into or create the cycle of opioid requesting.
You got to move away from that.
You got to move, because they may help
work
initially, but they certainly don't work well, and people almost always get rebound. So they may feel a little better with you, but they go home and now they're like wiped out for another whole day when they get the rebound on this. The key is to really try to break the migraine itself, from non-steroidals to things like dopamine antagonists. And the initial prochlorperazine study that actually happened when I was an internal medicine resident at UC San Francisco, where somebody thought this might work because of the mechanism of how this worked, and we would give people with migraines a liter of normal saline, and then we would basically randomize them to, you got something that might be a drug or might not be a drug with 10 milligrams of this, and the efficacy was remarkable. I mean, you didn't have to know who was in the placebo group because they didn't move, but you knew who was in the treatment group because they were like, woo, I feel great.
It works great.
It works great. So that works. And this is cheerleading too. People who have recurrent migraines, you have to say, gosh, this is so cool. This works. It was great, because they may come in saying, nothing works for me. And you have to really help them understand that this absolutely can. There are ergots. You can use the DHE and the ergotamines. Be careful in those. Nobody with heart disease should get that. Nobody who's pregnant should get that. People with kidney problems shouldn't get that. And honestly, I can't remember the last time I used that. The other stuff works pretty great.
Yeah.
And we have the triptans now.
Yeah.
They also, though, have some contraindications. Know that they're not for everybody. The ones are the focal migraines. So somebody who has hemi something with their headache, they don't get these. They don't get these. These you just don't. And as a last resort, you can use opiates, but the reality is we would really prefer not to use opioid medications for this at all. So these are bread and butter stuff for us. I think they're just frustrating because it's hard for the patient.
Yeah.
They're recurrent. They're miserable. And it's hard for us because the stuff we use does work, but sometimes we have all the complicated issues of how pain is managed and felt. And so we just have to all be patient with migraines because it's just hard for everybody to have those. Now, one of the cool weirdo kind of headaches that I think are just amazing are cluster headaches. So at Harbor, my entire first 15 years of my career at Harbor, we had a patient that came in with clusters every single year, came in multiple visits every single year, and generations of residents learned about cluster headaches from him. And he was so cool and so nice and would explain everything to everybody.
That's so funny.
He was
How
wonderful, wonderful man. It is men. This tends to be, this one is different men than women. This is a lot of men tend to get this. And this presents often seasonally. It tends to happen in certain seasons. It tended to be winter time, sort of late fall, winter. And it happens in clusters. That's the whole point. It's called cluster headache. It is unilateral. It is only 30 to 90 minutes usually, but it can happen in multiple episodes daily over weeks at a time. So once it starts, they usually know they're in for it for a while. No prodrome. But what they get with it that's cool is they get tearing and they get rhinorrhea and they get conjunctival injection, which tells you that this is something more than just my head hurts.
Yeah.
There is something neurologic going on here that makes me tear, that makes one eye that makes one eye inject, makes one eye tear. That there's something here, which means why we treat it works, which it absolutely does. So the way to treat this, if you see somebody with a cluster headache, is first of all give them oxygen. Fascinating. Just basically, you can use 100%, you can use nasal cannula, but give them oxygen, and that does seem to help some people. But what works great is intranasal lidocaine. And this patient, he literally God bless the man, he'd let us go through all the steps. He'd every resident learn. It's like they would try this and it wouldn't work, and then they would try this and it wouldn't work. And he would never let them give an opioid. He absolutely said no. And then he would wait till they came across either an attending saying, go put some nose drops in there, or they'd read about it, and you put lidocaine in there. And what that does is that takes your sphenopalatine ganglion that's in there, you have a lot of little ganglions kind of up in there, and it numbs it. And it is actually magical. People can really get a lot of, in fact, they can even do this at home. He eventually ended up just treating himself at home and didn't come in anymore.
Clearly teaching everyone else about it.
Yeah, exactly. But there's a lot of options here. You can go to opioids, but often can really get this thing taken care of without. So cluster headaches, we don't see them that often, but they are, once you see one, it's like, oh my gosh, I know what this is and I know what to do. It's really great. Now, attention headaches, which I am getting right now from talking about headaches, is getting attention headache. This is it is what it sounds like. It's tightness in your head. It's constant. It's bilateral. It lasts minutes to days. This tends to be end of day kind of thing. This is, I've been all day long. I've been reading.
Builds up on you.
Yeah, it's like, oh, my neck is tight. My head is tight. I've been concentrating on something. No aura. No nausea, no vomiting, no photophobia. And activity doesn't change. I can bend over, it doesn't change. I can sneeze, it doesn't change. Can be throbbing and pulsing though. So that just know that throbbing thing doesn't necessarily differentiate it. But these we just treat, there's lots of ways to treat this. Lots and lots of ways. It can be, and again, it can be across my forehead. Yeah. It can be here that hurts. It can be, it just always makes my...
The entire head that hurts. Just, that's a great one.
And the key is just chill. For me, it's a Chardonnay in the end of the day that takes care of my tension headache. You can use whatever works for you. And I think the main thing about tension headaches is to recognize when you get them, what triggers you for getting them, and how to kind of prevent them from getting bad by saying, oh, here it comes. I need to relax my shoulders. I need to go take a breath. This is something you can actually kind of abort these by knowing what causes them for you. So those are kind of the straightforward primary headaches.